name is Kintoya Mitchell.
I'm Dominique Williams.
We'll be presenting on arthritis. Here's the objectives. So we'll be defining the condition, stating the cause, clinical manifestations, and functional limitations, tests and measures, differential diagnosis, an overview of the rehab process, the likely outcomes, and then an overview.
So the condition of arthritis is the inflammation of a joint. There are many types. You have inflammatory and non-inflammatory, and the common types are rheumatoid arthritis and osteoarthritis. Pathomechanics for cause, you have articular cartilage breakdown. So for osteoarthritis, also known as OA, you're going to have mechanical wear and tear. And for rheumatoid arthritis, also known as RA, you're going to have autoimmune disease. So for OA, it being a degenerative disease, is the most common joint disorder in the U.S. It can be primary or secondary depending on presence of pre-existing conditions. It is characterized by progressive biomechanical joint changes, including degeneration and loss of articular cartilage, joint capsule contracture, loss of periarticular flexibility, and increased intracapsular pressure. For a degenerative OA, is secondary to excessive load, inflammation, trauma, surgery, congenital malformation, or long-standing disc derangement. For RA, it's a chronic systematic inflammatory disease of connective tissue. It is characterized by spontaneous flare-ups. It primarily involves tissue inflammation and is most destructive to synovial joints when compared to OA. Ankylosing spondylitis is a chronic and progressive rheumatoid disorder. It can be inflammation of fibrous tissue affecting insertions of the ligaments, tendons, and capsules into the bone. Gout is the most common form of inflammatory arthritis in men older than 40 and appears to be increasing in prevalence. It stems from dietary changes, obesity, environmental factors, renal impairments, and in some cases, drugs. It leads to increasing levels of uric acid in the bloodstream, causing inflammation, joint swelling, and severe pain. For juvenile idiopathic arthritis, this was adopted as an umbrella term to indicate a disease of childhood onset and is characterized primarily by arthritis of no known etiology. Juvenile rheumatoid arthritis is a group of diseases that are manifested by chronic joint inflammation. Psoriatic arthritis is an inflammatory form of arthritis associated with a chronic condition called psoriasis affecting men and women, and it can manifest in several patterns. And then we have reactive arthritis. It's caused by an infection in the body, and it often clears up on its own within a few weeks or months.
Okay, so first we have the clinical manifestations and functional limitations of RA. RA. Some clinical manifestations include redness, morning swelling, morning stiffness, and increased joint pain with activity, and some functional limitations would be impaired mobility, muscle performance, balance, and limitations in activities of daily living. For OA, it's similar. So you have the morning stiffness, increased joint pain, crampiness, and loss of range of motion, and this will lead to impaired mobility, muscle performance, balance, and limitations in activities of daily living.
So factors that increase a person's OA and RA risk, you have obesity, which that can be the extra weight adding on more stress to the joints that bear weight, such as the hips and knees. Age, cartilage and synovial fluid can break down and worsen over time. Sex, females are at higher risk than males. Genetics, some people have difficulty forming cartilage. That can be just due to your family history. Past injury, so joint injury alters neuromuscular control and biomechanics around the affected joint, which may contribute to cartilage degradation. Also can occur with post-traumatic OA. And then for jobs or occupation that require repeated and prolonged squatting, bending, kneeling, and twisting movements.
Okay, for tests and measures, for tests you do a physical examination. So when you first meet the patient, just noticing their posture. So if they have reduced kyphosis or lordosis, and also like looking at their gait while they're walking to see if the patient compensates on one side compared to the other. For range of motion, you can do active and passive range of motion to test the spine. And for palpation, you're just like feeling on the spinous process to differentiate from paraspinal muscle hypertonia hypertonicity, and you can do some manual muscle tests or manual muscle selective tension testing for the different muscles. So this will help decipher a patient's locational pain, or if they have myelopathy, which is spinal cord compression, and see if it affects the upper motor neurons and causes spasticity, ataxia, hyperreflexia, and positive Babinski, and doing some deep tenoid reflexes to assess the integrity of their motor system and upper motor neurons, and some special tests. Of course, this is going off your own clinical judgment, but I thought the vertebral artery test would be a good one. You have to do that one before the Sperlin test to make sure, like in the cervical spine, that the vertebral artery isn't being compressed. And for measures, of course, knowing their medical history, making sure they do a blood test to like really decipher which type of arthritis they have. Doing an X-ray would help identify the presence of OA or RA, and then CT scan, MRI, and the medication they take to help with any inflammation or anything. And then the straight leg raise test. He said, well, Dr. Carter said a different one for sciatica, but from the research, they had a straight leg test, like in the article.
So for differential diagnosis, you have rheumatic diseases, trauma, regional conditions, bone conditions, neurological, and then back pain. So for rheumatic diseases, you have diseases such as fibromyalgia, polymyalgia rheumatica, ankylosing spondylitis, degenerative joint disorders, diffuse idiopathic skeletal hyperostosis. Trauma, you can have fractures, dislocations, soft tissue injury. Regional conditions can include myofascial pain, osteomyelitis, septic discitis, septic arthritis, synovial cyst, and torticollis syndrome. For bone conditions, you can have Paget disease, osteomalacia, osteoporosis, and metastatic tumor. Neurological, you can have meningitis, CP, paralysis of cervical muscles. For back pain types, you have mechanical, non-mechanical, and visceral disease. So for mechanical, this can be a lumbar strain or sprain, degenerative conditions, herniated disc, spinal stenosis, compression fracture, or a congenital disease. Non-mechanical can be neoplasia, infection, inflammatory conditions such as Paget's disease. And visceral disease can be pelvic organ disease, renal disease, aortic aneurysm.
Okay, and this is just a chart so you can decipher which type of arthritis that they have, like choosing like basically if they have OA or RA, depending on the symptoms that you're sampled with. And then now we're at the rehabilitation process. So the primary goal is to restore function and manage pain through the phases of the disease. So for the acute or maximum protection phase, you're educating the patient, doing some kinesthetic training, decreasing acute symptoms, and you're initiating neuromuscular activation and control. For subacute, you're doing you're still educating the patient on their posture and like any body mechanics that could help relieve some of the stress that they're presenting with in their spine. You can increase mobility and develop cardiopulmonary endurance. And then for the chronic or minimal protection phase, you are continually educating the patient and spinal control progression and self-maintenance, and then you're improving muscle performance and increasing mobility and cardiopulmonary endurance.
Likely outcomes. So certain interventions to manage a disc lesion. So for passive cervical retraction, you can begin with the patient in supine with no pillow under the head or neck. Gently nod the patient's head and allow the neck to flatten against the treatment table. If the neck is deviated or rotated to one side, moving the head and neck backward to the midline must be done first. For progression, you will progress the retraction to hyperextension of the cervical spine and then progress to rotation. Patient education, just continue to identify the key factors that centralize the symptoms, such as posture or their sleeping position. Traction, this can relieve patient symptoms, and dosage is at an intensity that causes vertebral separation. So as we've learned, traction can be a temporary thing, it's not always certain. Indications for surgery, upper or lower extremity radiculopathy caused by nerve root irritation and who have failed conservative measures. a laminectomy, partial or hemilaminectomy, or a complete laminectomy.
Okay, and this is an overview of everything we just went over. So we went over the conditions and pathology, pathomechanics, the clinical manifestation, functional limitations, test and measures, differential diagnosis, the rehab process, and the likely outcomes.
Okay, so thank you all for creating a teachable moment. So again, everybody's doing an excellent job with the presentations, but I have to fill in gaps with what you can see on the National Physical Therapy exam if you don't address it in your presentation. So special tests, these are excellent special tests that could be performed to rule in and rule out arthritis in the spine, and I want to address specifically the cervical spine. So we're talking about OA and RA. Great. So with OA and RA, especially RA, if someone is referred to you with cervical spine, osteoarthritis, or rheumatoid arthritis, you most definitely, before doing any kind of treatment, you want to perform the Sharp-Purcell test. Now, why is that? Because the Sharp-Purcell test is actually specific to those who had rheumatoid arthritis. That test was developed utilizing patients with rheumatoid arthritis, okay, of the cervical spine or anywhere in the body. So you want to do the Sharp-Purcell test to assess the integrity of the transverse ligament, okay? So if the transverse ligament lacks integrity, what happens with forward bending or flexion of the spine or subcranial spine, what's gonna happen is that C1 is gonna translate excessively anterior with flexion of the spine. So that means that if that happens, typically this transverse ligament is not intact, okay? So we always want to assess a Sharp-Purcell test. So what am I saying? If you get a test question and the patient has cervical rheumatoid arthritis and you get a list of special tests that you should perform, like it says which test should be performed, the test that should be performed is the Sharp-Purcell test. You see? So you need to know that. All right. Okay. The straight leg raise test is a test that can be utilized to assess sciatica. So also your piriformis extensibility test could be used to differentiate that as well. In addition to your hamstring 90-90 test, they call it now the 90-90 straight leg raise test, but it assesses hamstring extensibility. But it could play, the hamstrings just could play a role in sciatica, so you just want to rule those out as well. But the straight leg raise test is a test for sciatica. All right. Why would you do the vertebral artery test?
I'm just making sure that the artery is trapped.
Oh, okay, so that's good, because if someone has arthritis or OA or RA, they could have degeneration, especially in the subcranial spine, especially in that C1, C2 area, where the vertebral artery transits. It could pose a problem because you have decreased spacing in that area. So good job. All right, but this right here is standard if someone has cervical or rheumatoid arthritis.